You're listening to Streetside, the Street Medicine Institute Student Coalition podcast.
Hello and welcome to Streetside, the official Street Medicine Institute Student Coalition podcast. I'm your guest host, Michael Brennan, and I am very pleased today to have two nurse practitioners from Philadelphia, Kara and Lydia, who will be sharing about the Xylazine wounds that they have been treating for years in Philadelphia. So welcome, Kara and Lydia, and I'm going to ask you to start by taking a moment to introduce yourselves. Kara, tell us about yourself.
My name is Kara Cohen, and I am an adult gerontology primary care nurse practitioner, and I'm also a certified wound specialist, and I work for Project Home's street medicine team in Philadelphia.
And Lydia?
My name is Lydia Williams. I am a family nurse practitioner, and I am also a certified wound ostomy and continence nurse. I work for Project Home in Philadelphia.
Fantastic. Welcome to you both. So I'm going to ask you, Kara, first, if you would help us. We're going to be talking about Xylazine today, and I'd ask you the history of Xylazine a little bit, when it came to this country, from where, and what you know about Xylazine.
Yeah, so I think we're still learning a little bit more about Xylazine. So Xylazine is also known as Tranq, and it was a veterinary tranquilizer, and it's a synthetic non-opioid drug. It's an alpha-2 adrenergic agonist, so it has like a lot of sedative effects, which is hence the name Tranq, where it can, affect the muscles and relax the muscles, and also create some respiratory depression. It is not ever tested on human use. It started to infiltrate the drug supply, I think, in Philadelphia. I'm not talking about necessarily when it came into the country in general, but it started to really hit Philadelphia around 2018, which we didn't know it was in the supply, but that was when we first started noticing it was there. Philadelphia is one of the epicenters of Xylazine in the United States, and Philadelphia and Puerto Rico are kind of the hardest hit. Definitely, we remember when people started telling us they were talking about Tranq. We had no idea what it was. We started Googling it, and we were like, I think they're talking about this Xylazine stuff. Up until that point, we did start to notice things like wounds, and we thought that there was something in the cocaine. So we didn't know what was going on at first. I remember looking around, talking to Lydia, what's going on with all of these different wounds, and we didn't know what was happening with it.
Lydia, I'm going to ask you, are there other nicknames on the street for Tranq or Xylazine? Do you know of any other names?
I feel like most of the names that are used in Philadelphia are Tranq. I feel like I haven't really heard too many others. It's pretty consistently Tranq. And the other thing we noticed in the beginning when we thought that it was in the cocaine supply is, number one, that there were wounds that were like circular, almost like punched out lesions that were like necrotic, like black areas, right? And it was a lot in our population of people who were not injecting. And that was the part that really had us like, what is going on? That's why we thought that it was in the cocaine, because we had lots of people who were not injecting drugs saying, I don't inject drugs. Because we were like, are you injecting drugs? Like, I never inject. I only snort. And we had lots of people who were doing like combinations of fentanyl and cocaine. So we thought, oh, this must be in the coke. Cocaine is like a stimulant. It can cause like necrosis. So we were like, this must be in the cocaine. But then we later found out as time went on that it wasn't the cocaine, it was the Tranq in the fentanyl supply.
How did you find that out?
The city had done some testing. They started to, I believe we had, and correct me if I'm wrong, Kara, we had some increases in overdose, and the epidemiologist in Philly decided that they were going to test the drug supply like they frequently do that, and they started to notice that Tranq was in 80 to 90% of the drug supply.
Yeah, by the time 2021 rolled around, we realized Tranq was in there. It was in over 91% of the drug supply, and today it's in over 98% of the drug supply. So to the point where we don't test for it anymore. We just assume that all of the dope, if someone is injecting opiates or fentanyl in Philadelphia, we just assume that it is Tranq.
And you use the word injecting. I'm going to want to clarify that.
I'm sorry. So if they're using any kind, so a lot of our folks do use injection. They do use drugs via injection, but also any kind of fentanyl use. So if they're using any kind of, what would be, the dope use. So if they're snorting it, smoking it, however they're ingesting it, it's basically it's all fentanyl. There's like very, very little heroin left in Philly, and it's all trank at this point.
Do you find xylazine in the cocaine or crack supply at all?
Yeah. So in Philadelphia, there's almost everything and everything. So we have patients who strictly were using like crack cocaine, and we've had people overdose on crack cocaine. We also have patients that just for years have only used meth. And then when we're testing their drugs, fentanyl is coming up, and not in small quantities.
Okay, the fentanyl's there. Is the
fentanyl,
xylazine,
well, so
the fentanyl's laced with the xylazine, and they're getting it all?
The drug supply, all of it has xylazine in it. So 98% has it in there. So they just started doing, we use LabCorp testing, and I feel like they have started doing some xylazine testing, and I have seen it. If there's fentanyl, there's xylazine, like they're together. Very rarely are we seeing like just fentanyl. It's fentanyl and xylazine.
So what determines if the xylazine is in the drug supply from top to bottom? What determines who's going to develop these skin lesions? Like, is it universal?
So this is such a good question, because there's so much that we don't know about it, because again, it was like never designed for use in humans, and this is not how we use it in veterinary use. So there's so much thought to be related to the microvascularization and vasoconstriction, that it is causing some sort of like localized necrosis, which we suspect, we don't know, but that is why if people are doing speedballs or 1-in-1, sometimes they call them that in Philly.
Please explain that. What's a speedball?
So if someone's doing like a bag of Coke and a bag of dope together, that's a speedball, or sometimes they call that a 1-in-1. And then that's where we see sort of the worst wounds, whether they're snorting it or smoking it or shooting it. Those are the wounds where they tend to be sort of the most necrotic. But a lot is still not understand about like the pathophysiology about how it is working.
I will say that despite people getting wounds that are not injecting, we do find that people who are injecting, the wounds are more severe. So folks who are generally snorting, they may develop a wound, but they're usually of smaller size. And then the folks who are injecting, the wounds are a little bit larger and more necrotic. That's generally what we see.
And my understanding is that it has nothing to do with the site at which you're ingesting the xylazine.
Correct.
It's disseminated, it's distal from wherever you're getting it. Is that true even for the injection?
It can be. So there are some people that will inject and they will get a wound where they're injected. But there are plenty of other people that have injected, say, in their thigh, and then they've developed a wound on their calf.
Okay.
So that has occurred.
Or even their arm.
Yes.
Right? I mean,
they will say, I never injected my arm and I don't know how I got this wound, but it appears to be a xylazine wound. And it's really not well understood. We all were like, what is going on here?
Kara?
I do think some of these like larger wounds, some of the ones that we see on TV, or a lot of the ones that have led to, kind of these fears around limb loss, a lot of them do have a secondary cause. So there's the primary cause where maybe the wound occurred from this damage to the vascularization that initially occurred from the xylazine. And then if they are injecting into the wound, there's a secondary trauma. So it also becomes like a traumatic ulcer. So that does create the additional challenges, and that's where you see the wounds that are going down to the fascia or the bone.
And you touched on this, but I want to dig a little deeper. That you talked about the microvasculature being important in this, that it's causing necrosis. Can one of you just please explain that to our audience that might not know those words even?
So what's happening, like cocaine is a stimulant, just like xylazine is not a stimulant, but what they're proposing is that it's causing like death to the vascular tissues and the vasculature, like almost burning through the veins. I feel like people are explaining it. And then what that does is it causes necrosis or death of the tissue in that area. And so then that's why you're getting those black necrotic eschar covered ulcers. You
both are on the front lines of something that is sweeping the nation and the planet. I'm wondering, what are your resources? Who do you go to for guidance on when this was first starting to be recognized? who did you turn to? Each other, or is there some other authority that understands the epidemiology and the pathophysiology of xylazine?
There were definitely a lot of other folks. Like we have a lot of large health systems in Philadelphia. So there's Temple Hospital, there's Jefferson. So I feel like there were lots of doctors and researchers that were doing work to try to figure that out. But in the beginning, no one knew what it was. So it was still a point of like figuring out what this was. And so in the beginning, we were just scrambling. Like we all were scrambling. We didn't really know. And I think it wasn't until like around 2020 when the Health Federation of Philadelphia like brought a lot of people together to organize all of us who were like seeing these things. And then we started to develop like a collaborative of like different community organizations, different providers from different disciplines in the hospital. And then we started to kind of work together. But really in the beginning, we didn't know. We were just trying to figure out what it was. And I've been certified in wound care for 15 years. And so in my mind, it was like, all right, I don't know what's causing this, but I do know the general principles of wound healing. And so that's what I'm going to do. Until I figure out what's going on, we're just going to treat the wound and then we'll figure out the other stuff when we have more information. But even if you like do a search on like PubMed or something like that for xylazine wounds, there aren't that many like articles about it.
I've done that search. Okay. As a nurse practitioner in Rochester, New York, seeing xylazine wounds, I went online looking for information. And what I found was the article from the public health in Philadelphia that I think one or both of you were involved in.
Yeah, Lydia helped formulate the guidelines.
Formulate that. Yeah, the guidelines. So that's been my guiding light as a practitioner on the ground, and is that article that you were involved with. Tell us about that.
So the substance use prevention and harm reduction, department of the Philadelphia Health Department. I'm trying to think of the exact year, but like they had like a change in leadership, and the new director decided that he wanted to really try to understand what was going on and what needed to be done, because he came in and recognized that like there was an issue where we had all of these wounds and we did not know what was best to do for them. And so what he did was he determined that we needed to have like a morbidity and mortality review, and connected with like lots of local people, local clinicians who worked in multidisciplinaries. Like some of us worked outpatient, some of us worked in methadone, some of us were physical therapists, and we all came together and did like a morbidity and mortality review. And then out of that review, we developed the guidelines. So we sat down and we like went through those. I think there were maybe 6 of them total. And we went through the morbidity and mortality review. And then at the end of it, we basically like met with the director and he compiled like general themes in each of the presentations. And then we went through each of those different themes to figure out what things, whether we felt like the person we presented got those treatments, or we felt like this is what they needed and it didn't work out for them, but this is what someone else would need. And that's how we developed the guidelines, by doing a morbidity and mortality review.
So say more, Lydia, about how you developed treatment protocols for xylazine wounds.
So we didn't have data. So what we had to do was just use our experience from the morbidity and mortality reviews to say, okay, when we did this particular treatment and we had this type of communication with the other outside providers, and we had this kind of discharge planning, and we had this kind of housing plan, and this kind of social service plan, and this kind of opioid use treatment plan, these are the things that worked. And so this is a guideline to say, this is what we believe in our experience of dealing with this for the past few years and being like ground zero basically for it. These are the things that we have seen work. And in the guidelines, there is some information that says like, we need more data. And that's what's happening, I feel like, in Philadelphia, where they are doing more data collection, and there are definitely some providers at other, like, some of the larger health systems that are really looking at very specific interventions, whether that's like, artificial or skin substitutes and how that helps to improve wound closure and decrease amputations, or like low barrier harm reduction outpatient wound care clinics. So people are pulling data and starting to formulate that now, but we really felt like people are going to start seeing this, and we should put something in place to assist them, because we know how it felt for us to not know what to do.
Thank you for all the work you've done. Kara, Lydia just spoke of something that I want to ask you to share more on. Is there's the wound, and then there's the patient, and then there's the environment, and there's holistic care. Can you say a word about what needs to be focused on to heal these wounds?
Yeah, so I think that, there's a lot involved in wound care. And really the most important thing is, patient-centered care. And what we were kind of seeing, and this is sort of where I think street med sort of informed the best practice, is we were seeing a lot of our folks who, had been going to the hospital for some of these wounds because, they appeared like wounds where previously we would send people to the hospital, and they were being advised very frequently that they needed amputations, or sometimes they were even getting amputations earlier on. Or, they'd be advised they needed an amputation and they just wouldn't go near the hospital. And so what we were trying to do was do lower barrier harm reduction wound care, but consistently and over a long period of time, which we call longitudinal wound care, of doing, a consistent practice, high quality over a long period of time with the same patient. And we started seeing progress in that people were able to close the wounds and achieve wound closure and avoid limb loss and maintain independence. So I think that was something where we really saw that then we were able to take what we learned from that and those patient-centered approaches and start teaching people in the hospitals, like, hey, when someone comes to you and they have a severe wound, telling them that they're going to lose their limb, if they're not actually on the verge of losing that limb, is actually going to prevent them from coming back into the hospital. We also saw a lot of like over antibioticing of wounds, because sometimes in these wounds you will get like a red ring around it that is because the wound has been there so long it's stuck in what they call the inflammatory stage, which is just a stage of wound healing, but it's not an infection. So we saw lots of antibiotics, and just sort of realizing that people needed basic education. We needed to like empower people to realize to keep their wounds covered and to keep them clean, and that an antibiotic won't replace high quality, consistent wound care.
Lydia, tell us more about antibiotics. Do these wounds get secondarily infected with microbes, and do they sometimes need antibiotics? And if so, which, is it MRSA, or what are you seeing?
They absolutely get infected sometimes. It's possible. And I feel like in our area, we are using a lot of Bactrim, and we have actually been advised to not use as much doxycycline because there's a lot of resistance in the area. Also, one of the infectious disease doctors that we have worked with in the collaborative was saying that she had noticed in a lot of these wounds that there was more strep infection. And so that was kind of surprising. So that's one of the things that we're finding in wounds. And so I feel like largely my number one go-to when I'm starting is Bactrim, but it will depend on what the resistance is in your area.
Are you culturing all these wounds?
We do not culture.
No, you don't.
Actually, in wound, in practice, in wound healing, in general, you don't culture unless the treatment that you're doing is not working and you think that there's some other bacteria that's the cause. Because a lot of times when you're going to culture, especially a chronic wound, so this is different than an acute wound. When you're culturing a chronic wound, there's going to be bacteria there. There's lots of bacteria there. But it doesn't necessarily mean that it's infected, right? So 10 to the 5th colony forming units, that's generally infection. So a lot of times what happens is when people culture the wounds, they get the report back and then there's some bacteria there and they think that it's infected, but that's not true. There's always bacteria in a chronic wound, and a lot of times you need something topically on the wound that's going to deal with the bacteria that's at the wound bed, right? And also the biofilm, which is like, when you wake up in the morning and you have that little film on your teeth. So the bacteria develop like a little layer over top of the wound, which is a biofilm. And oral antibiotics, they've done studies to show that it does not affect the biofilm. So you need a topical dressing. Even sometimes when wounds get infected, you need an oral antibiotic for like cellulitis or other infections, sepsis, etc. But you also need a topical antimicrobial to treat the chronic biofilm of a wound. And that's what we found in these Xylazine wounds. So we do not routinely culture unless there's a reason to. Most of the time we are treating empirically, like I'm seeing a patient that's had a wound for 3 months. I know there's biofilm. So I automatically begin a treatment to treat the biofilm.
Great. We're gonna let Kara answer this next question. When we talk about biofilm on these wounds, what are you using? What products are you using to get rid of the biofilm?
Oh, Lydia would have been good for this one. I mean,
Well,
we use a lot of Vash. We do that to break down the biofilm. I feel like we will sometimes, if there's a heavy bio burden, we'll use some Dakins. So those are kind of two of the major ones that we use for cleansing. I think that a lot of times just we also just do a lot of education on what not to do, because some of our folks, like, they're just so afraid of the wounds being dirty that they're using things that are cytotoxic to the wounds. So they'll be pouring like hand sanitizer or alcohol, which is also painful, or like non-diluted bleach or iodine. Peroxide is a huge one. Like people really love to pour peroxide on the wounds, and it just sort of is cytotoxic and it stops the granulation tissue. So it's, as much as it is about like educating, like if you didn't have access to something fancy like Vash, or you didn't have access to like Didaxol, you would just use like water and things like that. But some of these other dressings are very helpful as well, but you don't necessarily need a fancy specialty dressing or a fancy cleansing agent to achieve like wound progression, positive progression.
Before we leave the topic of secondary bacterial infection of these wounds, I consulted with a nurse practitioner, infectious disease specialist recently on a resistant MRSA in the wounds, and she recommended gentamicin 1% ointment. Is that something you've seen or used, or when is that appropriate?
So gentamicin is great. The only thing is, I feel like in the population that we serve, which is out on the street, generally it needs to be applied twice a day minimally, and I think the recommendation is 4 times a day. So in our population, while it may have very great activity for that particular bacteria, I would probably try to use something that has more broader spectrum coverage, because addressing twice a day is like too hard for someone to do. So a lot of times if I'm thinking about wound topical care, and I'm thinking about in an ideal world, I would use a sustained release iodine dressing on a wound to clear up biofilm. They've done a lot of studies to show that iodine actually has sustained release iodine has superior function on biofilm versus silver. Now, silver is great. So if I had my number one choice, I would have a dressing, whether that's in a foam, a gel, or a pad that had sustained release iodine in it. That would be my top choice. And then my secondary choice would be something that has a high potency silver. So I love, especially I love combining wounds to get like more bang for my buck. So if somebody's got a wound and it looks like there's biofilm, but there's lots of drainage, I love a silver alginate and then a foam over top and wrapping it. And then that's something they could change only like every 2 days. So like there are some dressing supplies where you can get longer wear time. So I'm always trying to pick a topical dressing where I can get bang for my buck. So if they have lots of slough and I feel like it's dry, then I may reach for like a Meta Honey, which is going to provide bacterial support because it has a high osmolality, right? So it's going to pull fluid into the wound and it's going to kind of flush out the bacteria, and the bacteria can't really survive in that environment, but it's also going to help pull extracellular fluid into the wound, and then that's going to loosen up the slough, so we're going to get some good autolytic debridement. So I love bang for my buck in wound care.
Yeah, I love.
The one thing I want to say, and I think this is something we've all kind of noticed, is that, like, again, like, I think people don't understand how much specialty goes into wound care. We do just try to teach some really basic wound care to make it accessible to everybody, because there's not a singular dressing that will come in that will replace high quality, consistent wound care. So it's always better to do a really simple dressing if you're doing like Xylazine, Telfa, whatever, Meta, Honey, Telfa, ABD pads, Cling. That's better than something super fancy if you don't have the access to keep on doing the fancy thing. However, the thing that I want to say is, as you could just hear from talking to Lydia, there's so much expertise in this. So we do get a lot of, tell me everything you know about wound care in an hour. And we're like, like you wouldn't do that for any other field. So I do feel like one of the things that Lydia has helped elevate is that this is a specialty. And it's something like when you have the expertise, you do get the results. So I think we're always encouraging people, just as Lydia encouraged me to go back for I got, my CWS this past year because Lydia has been encouraging me to do it for the last several years. And now we're encouraging other people to go and get that extra education because, it's not always easily accessible. And if you're on street medicine, there's a lot of online courses you can take to sort of gain the expertise. And when you do take those online courses, you'll see that the dressing is just part of it. It's like one of the things they talk about. It's not going to be just a dressing algorithm. It talks about addressing the underlying causes and the overall health. And that is really to close a wound, you need to focus on everything related to the patient. You're talking about where are they sleeping? How are they sleeping? Are they eating? How much are they eating? How much are they being hydrated? And then the dressing is part of it. And, are you dealing with their emotional reaction to the wound and all of these things? But I just want to, I'm so grateful for Lydia for just elevating how important and how, this is just, it's a specialty.
It is. And I, as a primary care person, I can't help but feel some anxiety when I'm facing some of these wounds. And what dressing do I pick now is challenging and leads one to feel somewhat incompetent. Mm-hmm. So maybe I need to go back and get further training.
It would definitely be helpful, but everyone is not going to specialize in everything. So I think it's okay to have an understanding of the preliminary things that a wound may need, and then to refer out or to ask for support. So I always tell people, I don't expect someone who has no experience in wound care or who has no certification to know. That's not the part that's really important. You may not know what to put on there, but you may know, man, this person's diabetic. I can manage their diabetes. Okay, this person doesn't have social service support. Okay, I can refer them to social worker. So you don't have the support to know what to put on there, but most clinicians, I feel already have all of the other tools to do the other parts, and that's so important.
I'm loving something you're bringing forward here is that I'm struck between the words addressing and dressing, and addressing the overall picture of the patient and worry less about the dressing. Mm-hmm. That addressing is maybe trumps is more important than the actual dressing you're putting on. Is that accurate?
That is accurate. And that's really great. And I feel if you are a provider that's trying to figure out, what to do, those things that you already know are really great. I love when somebody refers someone to me and they're they have a pressure ulcer. And then they say, they have a pressure ulcer. I've already ordered the support surface. I've talked to the family about turning and repositioning. We got them some adult pull-ups. They're going to be changing the pull-up every few hours. I've talked to their daughter, and I'm this is great. Yeah, right. All I have to do is figure out the dressing. Everything else is done. This is the easy part. Yay.
Yay, great. So my takeaway as a primary care street medicine person is when I see xylazine wounds, I'm going to get rid of the biofilm with Bosch or any solution, and I'm going to use Meta, Honey, or Xylazine on the wound with a non-adherent gauze, and then keep it covered. Is that
That's
accurate?
That's a great start. It's
Okay.
a great start. And what happens is you start there, and then you reassess over a 2 to 4 week period. And if it's not working, you adjust. One thing I will say about Meta Honey, and I think this is in the guideline as well, but you do with Meta Honey, especially in the hot summer months, have to worry about the attraction of bugs. Oh. Okay. So Meta Honey is one of those things that I really like a lot, but I am hesitant to use it in the summer, and especially on limbs. arms, legs, because they hang down and then the honey drips down off the wound. And then the Meta Honey, because it's so concentrated, it can cause like some irritation to the skin around it. So you have to be mindful of that. But those two dressings are really good to start, and I like them both because they can be widely used in lots of people. Except for the silver, you can't be allergic to sulfa because it's silver sulfadiazine, and you cannot use it in pregnancy.
Oh, okay.
We also really like Triad, which is I use a lot of Triad. It's sort of an oldie
Never
but a
heard of
goodie.
it. What is it?
A lot of people haven't. So it is an autolytic debrider, and it kind of has the consistency of like butt paste. And so it's kind of how you have that problem with Meta Honey where it can, just sort of emulsify and macerate the peri-wound area. If Triad is on a peri-wound area, it will just remain intact because it's, protectant to the skin, like emollient. But you can also leave it on for up to 5 days on the wound bed, so you can change the outer dressing, but leave the topical treatment on. It does debride. You don't want to use it in infected wounds, and you don't want to use it in burns. But that's something that that's actually probably what we use a lot. And you can order Meta Honey is not typically covered by DME if you order in wound care supplies. It's not covered by insurance. Xylazine will be covered as if you have Medicaid, it will be covered as like a medicine would be covered. But Triad is often covered by DME. So if you're able to have the person's insurance cover the basic wound supplies, it will often cover Triad.
Thank you for that. That's a good clinical pearl. It leads when you talked about Meta Honey attracting bugs, maggots in wounds. Can you say a word about that?
So it's definitely an issue in the summer months. Usually what we have people do, I love to use diluted Dakin solution, and I flush the wound area with that, and then also would take a wet, moist gauze, like soaked gauze with the Dakin, and I will let that sit for maybe about 5 minutes or so. And then I will generally pick a dressing that's going to be I would use something that has lots of bacterial coverage. So if there's lots of drainage, I might use a silver alginate, or I may use a Meta Honey. And then I would have them change it the next day. Because the issue with maggots is that you're not always going to be able to see the eggs that are there, and then they will hatch, and then there will be more maggots there. The thing about it is patients can really feel that too, so they can there's more there, and they really can kind of be your partner in making sure that they're continually cleaning them out. But you do have to take care of them because, they do use maggots. There is a thing called maggot therapy, but the maggots outside are not sterile. So they can cause underlying infection. So you do want to remove the maggots.
Thank you. This has been tremendous. We're going to wrap up with 2 final questions for each of you. And the first of which is, if you could give our listenership one piece of advice for what they could do to make the world a better place, what would it be?
I would say willingness to be open and learn. And then always my favorite is compassion and grace.
Love it. Thank you. Kara?
Just as practitioners, just humility that I think, I always kind of say that we're a team, but the patient is the captain. So it doesn't matter if I'm the smartest person in the entire world. If I'm coming up with a plan and the patient doesn't want to do it, it doesn't matter. It's not going to be done. And sometimes I just think, especially in times where, the Xylazine crisis is so traumatic and we have seen just an increase in human suffering, I think it's really important to just instill our patients with hope. We give them hope through education. We give them hope through clear expectations and by showing up for them, and just to let them know that, how much we care about them.
That's beautiful. Thank you both. And lastly, how can our listenership connect with you and or support you in your work, or what can they do?
I love talking about wound care. I always tell people I could talk about it all day. So I welcome emails. My email, I can give it to you, or you want me to say it. My email is Lydia, that's Lydia, last name Williams, all together, lowercase, at projecthome.org. And you can email me there with questions. And I love to talk about this stuff and give feedback and support.
Thank you, Lydia.
I also welcome questions. I am really bad at email sometimes, so I can also give my email, and if I don't email you back, you should wait 2 weeks and email me again because sometimes it gets buried. Kara Cohen, KaraCohen @ projecthome.org.
And Project Home must have a website that people could access as well.
Yes, and so if you Google Project Home, HOME, Philadelphia, and then you Google street medicine, there'll be a little pop-up of our team, and our information is also on there, and they talk more about our primary care street medicine team. So that's like, I guess the final thing is we do wound care through like a lens of primary care. So, people are sometimes be like, oh, here's the wound care nurses. And we're like, well, no, we're the primary care team. We do wound care, but we are the primary care team.
It has been delightful to talk to the two of you. I appreciate the work that you do, but also the joy with which you do it. Our listenership has not had the opportunity to sit here looking at you, but you've both been laughing and smiling throughout as you talk about these horrible wounds. And I just love your spirit.
I just love working with Lydia. I am the least important person on the team. I have to always say that. Like, we have a really amazing team of Maura St. Leger, who's a family nurse practitioner, Liz Frash, Lydia Coe. We just hired a really wonderful nurse who's going to be coming on. We have an amazing street outreach team. I'm the least important person on it, but I just care about all these folks so much. We talk like every day, and I've been working with Lyd for over a decade, and I just learned so much from her. We just really have a good time together. So I'm not like celebrating the Xylazine wounds, but it's really just good to be in like Lydia's energy.
Yeah, I love this work. This is like my dream job. I've been looking for a position like this forever. When I decided to become a primary care provider, I knew that I wanted to blend primary care and wound care. So this is my dream job. So I love talking about this stuff. I think it's really fun to like collaborate with people, and I just like to have a good time. I'm just I'm just chill and fun, and
Awesome. Thank you both. We really appreciate you taking the time to speak here on Streetside.
Thank you.
The opinions expressed in this podcast are those of the individuals included and are not representative of the opinions of the Street Medicine Institute or the Street Medicine Institute Student Coalition. Do not use this podcast as medical advice, and instead see your own provider for medical care.